Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Today we're going to be demonstrating the mounting of diagnostic cast on the Hanau wide view articulator. The first thing that we will be doing is we will be using the springbow facebow to capture the relationship of the maxillary arch to the arbitrary hinge axis, and we will then proceed to mount the maxillary cast. Once we've completed the facebow, we will take a centric relation record to capture the relationship of the mandibular arch to the maxillary arch, and we'll proceed to mount the mandibular cast on the articulator. Having completed that, we will then proceed and we will take a protrusive record and lateral check bites to set the protrusive inclination, condylar inclination, and the bend and angle on the articulator. The springbow consists basically of three parts. We have the springbow assembly with the two ear rods that go into the external auditory meatus. We have the infraorbital pointer here, which gives us our third point of reference. What we're using today is we're using porion as our two posterior reference points and orbitale for the anterior reference point for our 3 points of reference. Then we have the transfer clamp assembly, and we have our bite fork, which we'll use to capture the relationship of the maxillary teeth. In assembling this, the easiest way to assemble it is to pretend that you're going to be putting it on yourself and just turn the facebow like it would be fitting in your own ears. If you take the orbital pointer and move it out of the way like that, so it's not going to be poking anybody in the eye when you're putting on the face. What we're going to be doing is we're going to put some wax on the bite fork and capture indentations of the cusp tips of the maxillary teeth, and then we have to capture this relationship of the springbow to the bite fork, and to do that we use the transfer clamp assembly. Transfer clamp assembly consists of 3 thumb screws labeled 1, 2, and 3, and if we position these such that they are facing to the operator, and we take our bite fork and we assemble this and just insert that into that little bracket and tighten the thumb screw here. And then if we loosen the following thumb screw such that everything is loose, we are ready to proceed with the next step in going to the patient and putting the wax on the bite rim and going from there. Before we proceed with putting the base plate wax on the bite fork, I want to point out a couple of details to keep in mind. On the bite fork there's a little line here, and when this is placed in the mouth, this is meant to correspond to the midline of the patient, or between the two central incisors. The other thing that you'll notice is that the bite fork has a bend in it, and it is meant such that when this is placed in the patient's mouth, that the little line inscribed on the center will line up with the two central incisors, and then that the offset will be onto the left side of the patient. And what we'll do is we'll try this in the patient's mouth before we put any wax on it. So if you just open, we're just going to locate that, and that's where we will position it once we have the wax on the bite fork. And it's important to try to keep this pretty much lined up with the sagittal plane of the patient. We'll now go over to our water bath. What I'm going to use today is I'm going to use 2 sheets of pink base plate wax to put this on the bite fork, and we're just going to wrap it around the bite fork such like that and capture the indentations of the maxillary teeth. What I'm going to use a water bath, and I've got it set for 130 degrees. The temperature setting is not critical. We just want to soften up the wax such that it's workable. So if we just lower it into the water bath and just let it warm thoroughly through and through. On some patients, you may want to use 3 sheets of base plate wax. It depends. If their occlusal plane is relatively flat, you can get by with 2. If they have a lot of curvature, a large curve of SPE, sometimes you need 3 sheets of base plate wax. The important thing to remember is how this is going to be positioned on the patient. So again, we're keeping it in mind just like we were standing behind the patient, and we're just going to wrap the base plate wax around the bite fork. If the wax starts to lose consistency and get hard, we can put it back into the water bath to soften it up again. The reason that we're going to put some wax on the undersurface of the bite fork is such that the patient can bite into this and just help maintain this in the mouth while we're doing the rest of the facebow. The undersurface is not really that critical. It just gives us something for the patient to bite into and to stabilize this and help us when we're taking the facebow. The indentations do not have to be large. We just need shallow indentations of the maxillary cuss tips. We're now going to go over to our patient, keeping in mind that we're trying to line that little line up with the midline, and we're also trying to keep the bite fork in the mid-sagittal plane. If the midline is off a millimeter or two to one side, it's not really critical. One thing that I can see now, we're probably a little bit a millimeter to the left, but that's well within the range of acceptability. Once this is cooled, we can take the bite fork out of the mouth and we can look at our indentations, and as long as we've got good indentations all the way around, we're doing fine. I go back and reposition it. You want to just bite down into that, Dave? Okay, good. Now, one of the things that you want to be sure that when the patient bites down into this, that there's enough wax, that they're biting into the wax, that the bite fork doesn't tend to tip. If you don't have enough wax on the inferior surface here, the bite fork will tend to tip. So right now he's biting down into it, and it's nice and stable, and there's not really much give there. The position in which he bites in is really not critical, so there's really no precaution that has to be taken other than just say bite gently and be sure that they're not biting too hard that they're going to hit the metal. So at this point we have our bite fork that we are ready to put the facebow on. In order to assemble this, the facebow and the bite fork such that the transfer assembly will slide onto this bite fork, we're going to use a little bit of lubricating jelly here, and we're just going to put a thin layer on the bite fork. Once we've applied the petroleum jelly to the bite fork, we can wipe off the excess. We just need a very thin layer just to lubricate. We're now going to go back to the patient. We're going to insert this into the patient's mouth, have them close down into it, and then we'll go ahead and assemble the facebow onto the patient's face. The bite fork is going to fit right into this little hole here, right next to thumb screw number 3, and we're going to ask the patient to help us in positioning the ear rods into his ears. So if you would just help us here, Dave, and just sort of grab each of these one hand and just tip it up a little bit. Okay. And loosen each of these such that it slides easily, and that if he positions it in his ears, can you get it in there, Dave? Okay. Once it's positioned in the ear, you can just check and make sure that it's seated nice and uniform. And now you'll notice that this can be lowered and the vertical height adjusted. Now remember, we're using our third point of reference, which is infraorbital notch. So we're just going to bring over this, swing it over the infraorbital pointer to correspond to orbitali, and we're just going to raise this facebow to that height, and then we're going to start tightening the thumb screws in order, of 1 being the first thumb screw that we're going to tighten. And while we're doing this, it's important that we grab the assembly such that we prevent torquing and tighten each one. And at this point, once we've got the vertical height adjusted, now we're getting our sagittal, and it's important that this be centered and it be sitting passively on the patient's face, so that if we just move it back and forth and just let it center itself, and again grasp the assembly and tighten the number 2 thumb screw, and then finally number 3 thumb screw. And once we've done this, go back and retighten each one of these, being sure that you have a firm grasp of this transfer assembly, not to put excessive force on the patient. At this point, we can move the infraorbital pointer to the side. We're done with this. Now, as I remove these from your ears, if you want to just open, and we let everything just sort of fall out, and we've taken our facebow and we've completed that portion of our demonstration. The maxillary cast, I want to review some of the specifications of this articulator that we have, pointing out important things that we check before we mount the maxillary cast. If you remember, the condylar element has basically 2 adjustments. The superior thumb screw here provides for the Bennett adjustment on the articulator. Prior to mounting the maxillary cast and the mandibular cast, we're going to set the articulator to average settings, and after we have mounted the maxillary and mandibular cast, we will then use our check bites to set the adjustments custom for this patient. So we're going to set our Bennett angle at 30, tighten the thumb screw on the superior. We have this mechanism here which allows us to adjust the protrusive condylar inclination. We're also going to set that at 30 and tighten that. It is critical that in the mounting stage that the centric latch be tightened such that the condyle is in a seated position. In order to loosen this, to set our protrusive later on, we will loosen it 2 full turns, and that will allow for our protrusive movement. But at this time, we want it tightened. If we look at our incisal pin, we will look at it. On the superior surface, there is a heavier black line. It is important that at this stage that this be at flush with the superior surface. And again, tighten the thumb screw. When we look at the incisal guide table, it is critical that this pin be centered left to right on our guide table and anterior posteriorly. If by chance this pin is not centered left to right, you will have to go back to the condylar mechanism and loosen this little Allen screw and on both sides and center the articulator and zero it out. This should have been zeroed out at the factory, and in most cases it should not be any problem, but it's important that you check this before you proceed with mounting your models. If the anterior posterior adjustment is off such that this pin does not sit on this line, that is a much easier adjustment to make. If we look at the undersurface, there's 2 screws here. If we loosen the larger of the 2, that will allow us to move that incisal guide table anterior posteriorly and move the guide table such that the pin is centered on the table, and then tighten the larger thumb screw, and we have that zeroed out. Having done that, we can proceed with mounting our facebow. Prior to attaching the facebow, we need to attach our articulator rings. If you look at the articulator ring, you can see that there's a flat side to this ring. On this articulator, the flat surface here is meant to face the posterior portion of the articulator. Right now we're going to mount the maxillary cast. So we're only going to attach the rim to the maxillary member of the articulator. Position it on the little guide pins and tighten it down. There are 2 ways to use the facebow to attach the maxillary cast to the articulator. We can use the direct method or we can use the indirect. And I'll demonstrate both methods and then I will go ahead and mount using the indirect method. In the direct method, we're going to use the facebow as we took it off from the patient. We're going to remove the two earpieces from each side and lay those aside. Having removed those, we're going to position the facebow such that this little hole here centers directly over the hinge axis of the articulator, rather than using the ear piece to center over the little rod here that would correspond to the external auditory meatus. This is based on the principle that the true hinge axis is anterior to the external auditory meatus. In most instances, it's going to be somewhere in the neighborhood of 12 millimeters. That's an approximation for the purpose that we're going to be using. That is accurate. We're going to now position the facebow on the articulator. One of the things that we've got our 2 points, assembly to posterior. We now have to raise this facebow such that our third point corresponds to the infraorbital pointer on our articulator. And so we need to raise this until that touches. What we're going to do at this point is we're going to insert this transfer assembly rod into this orifice such that the O-ring fits into the large orifice. We raise our facebow, we can insert that in, and we can lower the facebow down again and use that as a stand. We can now close the upper member of the articulator, and we can adjust this appropriately such that the pin is on the table and that the infraorbital pointer is touching the inferior surface of the infraorbital pointer, and we can tighten this at this point. I should mention that it's critical at this point to make sure that this table is flat. You can see that right now it has a little looseness to it. We want to make sure that it's flat and tighten the smaller of the thumb screws on the bottom. Again, verifying that our pin is on the table, that the infraorbital pointer correspond to each other. At this point, we can go ahead and proceed and mount our maxillary cast. Before mounting your cast, it's important that you examine the model and make sure that there are no bubbles that would prevent the model from seating into your facebow registration. We can tip this back. We can seat our maxillary model into the bite fork. We can add plaster, close the articulator down, and we've mounted our maxillary cast. One of the weaknesses with this system is that at this point we have no way to support this bite fork, and as we lower this down, sometimes you'll get a distortion. So using the indirect method will allow us to give a little bit more support for this bite fork. Today what I'm going to use to mount the facebow, I'm going to use the indirect method using the mounting platform supplied with the articulator. We're going to remove the facebow that we had just placed on the articulator. The only portion that we will actually be using of the facebow is the transfer assembly. We can lay the springbow aside, we can lay the elevating rod aside, and what we will be doing is inserting the transfer rod directly into the mounting platform. If we loosen the little thumb screw, we can seat our transfer assembly onto the mounting platform. What this allows us to do with this little cast support is to support our bite fork. That you remember when I demonstrated the direct technique, there was no way to support this. This gives me support for my bite fork, so I don't have to be quite so concerned about displacing that. This will fit directly onto the articulator like you would fasten a mounting ring directly onto the articulator. And at this point, we are ready to mount our maxillary cast. Again, we've got the transfer assembly, the bite fork mounted onto the mounting platform. We can position our maxillary cast into the bite we can position our maxillary cast onto the bite fork. We can mix up our plaster, and we can mount the maxillary cast, which we'll proceed to do. We've now rough mounted our maxillary cast. What we will come back after the plaster is set is we will add more plaster to make a neater mounting. While we're waiting for that to set, we can look at our mandibular cast when we want to verify again that we don't have any bubbles, any positive bubbles on the occlusal surface that would prevent us from seating our centric relation record when we go ahead and take that. While this is setting, we will go back to the patient and take our centric relation record, and we'll come back and mount our mandibular model. Before we proceed with our bite registration, it's important to practice positioning the patient in the centric relation position. What we're going to do is we're going to lay the patient down pretty much in a supine position. We're going to ask the patient to tip their head backward and just open gently. And centric relation should not be a forced position. It should be a rather gentle position. If you're using a lot of force on the mandible, you're probably getting a strained relationship, but it should be a gentle position that you can just repeat and just slowly close down until you first feel the teeth touch. And one of the things that it's typical to ask the patient whether they're hitting on one tooth or several, and in most instances the patient will be hitting just on one tooth. Are you hitting on one or several teeth, Dave?
Two.
Two. Left, right, both sides, either one?
Both sides.
Both sides. Okay. What we're trying to do at this time is determine the amount of slide that we have in centric relation and the direction of it. So if you just close gently, we can see that the mandible slides forward into centric occlusion where we have contact between the anterior teeth. And I'll duplicate that in a minute to demonstrate it probably a little bit more clearly. Open again for me, Dave. Just relax and squeeze. And we can see that he has pretty much a straightforward slide of about 1 millimeter. And there's just a very small vertical component and about 1 millimeter horizontal with very little lateral component to the slide. And that's what we're trying to capture when we take our centric relation record. Now that we've verified that we can reproduce centric relation on the patient, we're going to go ahead and begin taking our bite registration. In our centric relation record, basically what we're trying to do is we're trying to capture the relationship of the maxillary arch to the mandibular arch in the centric relation position. And what we're trying to do is we're trying to take an impression of the cusp tips of the maxillary arch and an impression of the cusp tips of the mandibular arch in a predetermined position, namely centric relation. What we're going to do is we're going to divide this bite registration up into 3 steps. We're first going to use a single sheet of pink base plate wax, and we're going to capture the impression of the cusp tips of the maxillary teeth. We're going to soften this again in the water bath like we did before. We don't need it real soft. We're just light indentations that we're trying to capture. And one of the things with a centric relation record, you're trying to keep it as thin as possible, and that's where we're using a single layer of base plate wax. I'm going to proceed to the patient now, open real wide, and position this against the maxillary teeth and just gently press it against the teeth, capturing the indentations of the maxillary teeth. And the first time I insert it is just to get a rough idea of how large I need to trim this. I'm now going to proceed and trim off the excess wax with the scissors. Now I realize that in doing this that I've distorted the wax, but I'm going to go back to the patient's mouth and reposition this. Now If in the process of doing this I distort it too much and the wax gets too cool, I may have to go back to our water bath, and we'll try it in and see how we're doing. And the key thing is that this should seat, and we should not get any rocking, which we do not. So we have a nice impression of the cusp tips of the maxillary teeth, and basically right now we have 1/2 of our bite registration taken. Having captured the indentations of the maxillary teeth, we'll now proceed to take the remainder of the bite, which is capturing the indentations of the mandibular teeth. And we're going to be using the green alu-wax to capture that relationship, and we're going to do it in 2 separate parts. We're first going to capture the relationship of the lower incisors, and then we're going to capture the relationship of the molars. In most cases, it's going to be the second molars of the patient. If we get the first molars, that's okay also. But what we're trying to do is we're going to have 3 points, and 3 points determine a plane. And when we take our cast, we can position them together again. So what I'm going to do is I'm going to go over a Bunsen burner, and I'm going to puddle a little alu-wax right in the anterior area here. We're going to wait until it starts to cool and chill, till it loses its shine. Then we're going to place this in the patient's mouth, and we're going to close the patient down into centric relation, capturing the relationship of the mandibular incisor teeth. In doing this, it's important that before we determine, you have a rough idea where these mandibular teeth are going to be hitting, and in a normal class 1 relationship, it's right behind the central incisors. And right now you can see that the wax is still rather fluid, and we're going to wait until it loses its shine before we insert this in the patient's mouth. You can see as I move it, it still is fluid, and if we went to the patient's mouth at this point, we run the danger of burning the patient. It's starting to lose its shine now. We're going to go back to the patient. I'm going to insert this in the patient's mouth, establish it on the maxillary teeth, and slowly just close the patient down till you just touch. Just close gently. Good, right there. It's important that the patient doesn't close down real hard. Just a gentle, till they just touch, and just let this chill. In order to speed up the chilling process, we can use the air syringe just to cool down the wax. And once we've done this, we can have the patient open. And now we can verify that our position is reproducible, that we can have the patient just close down into it gently each time. Open, just gently close down into it. And at this point, we have one of our 3 points. We have the lower central incisors. Now we're going to proceed, and we're going to put a little puddle of wax in the posterior area to capture our final 2 positions to establish our plane. We're going to just puddle wax again in the second molar area. If the patient that you're working on does not have second molars, use the most posterior tooth on each side. Once you get a little bit further forward than bicuspid, you may have to use a base plate. One of the things you just see that the wax has run a little bit, but that's not really critical. Again, just wait until it starts to cool. If you're going to use the air to cool it, it's important that you don't direct it directly on the puddle of wax. Okay, it's pretty much lost its shine. We're going to go back to the patient, position this, and capture our final 2 positions. Just relax, slowly close. Stop right there. If we look in here in the posterior, we can see that we've captured the relationship of the mandibular and maxillary second molars with the green wax. And if we go to the other side, we can see that we've captured the same thing. Now the important thing to check is that this is reproducible, open, and that we can just close into it, which we can. Open. We're going to remove the bite now, and it's critical that when we look at this, we should see nice, crisp indentations of the cusp tips. They should not be smudged. If they're smudged, the patient has bitten too hard, or we've not reproduced our position, but they should be nice, clean, crisp indentations. We've now completed taking our centric relation record. Just to review, we've got the indentations of the cusp tips of the maxillary teeth. We've got impressions of the cusp tips of mandibular teeth in 3 areas, 2 in the posterior, 1 in the anterior, 3 points determining a plane. We can now go back to the articulator and we can mount our mandibular cast on the articulator. We'll now use our centric relation record, and we will try that onto our mandibular cast to verify that it seats accurately. One of the things that you want to check is that there's no soft tissue impingement, and also sometimes if you've used a large amount of wax, you may have some very small indentations or protrusions that will not seat, and you may have to trim away a little bit of the excess. But in this case, we can see that our model seats nicely into it. We'll do the same thing and check the maxillary surface. Now that our mounting is set, we can remove our bite fork and we can proceed with mounting the mandibular cast. We will carefully open our articulator, loosen the thumb screw on the undersurface, remove the mounting platform, lay that aside. We will put on the lower mounting plate. Again, remembering that the flat surface faces posterior. When you open it up, you'll find that the 3 points here serves as a nice mounting platform. We will seat our bite registration onto the maxillary cast. We will then proceed with seating the mandibular model into the bite, and now we will check to verify that we have enough room for plaster. Having done that, we can go ahead and proceed and mount our mandibular model, which we'll do at this time. It's important when mounting this mandibular model that someone help you and hold that mandibular model firmly into the bite. I'm going to use one hand to hold the model and the other hand to add the necessary plaster. Doing it the first time, it'll work better if you can team up with a fellow student and you can help each other do this. It's always a good idea to place some plaster and force it into the indentations in the ring. Again, this is just a preliminary mounting. We can add more plaster later on to firm it up. We'll lower it down, and it's critical that you hold this while the plaster is setting. If you don't, you'll get a little distortion in your model, and your registration will be off. Okay. The next step in this process is to take a protrusive bite such that we can record the condylar inclination. For this, what we're going to do is first check the patient's centric occlusion, have the patient bite into maximum intercuspation, and look at the relationship of the maxillary and mandibular anterior teeth. And in most instances, our protrusive bite will be taken in an edge-to-edge bite of the patient. And have the practice of doing this with the patient before you actually insert the wax. And usually what I ask the patient to do is bring the jaw forward and pretend that they're biting into a sandwich and bring their teeth together like they're biting into a sandwich. And that is the relationship that we're going to try to capture with our wax bite in a moment here. It's important that we look in the posterior and determine at this point what the separation is between the maxillary and mandibular teeth, because that will give us an idea of how much wax we're going to have to need to capture this relationship. And in this case, it looks like we've got 2 to 3 millimeters, so we're probably going to have to use 3 thicknesses of pink wax such that we get good indentations of both the maxillary and the mandibular teeth. And in taking this bite, it's important that the patient open, bring the jaw forward, and then incise like they're going to bite into a sandwich. Oftentimes what patients will do, if you don't give them good instructions, is they will bite into centric occlusion and then slide the jaw forward, and you end up with a wax bite that has a lot of distortion in it. So it's important to practice this with the patient. In order to assure that we have adequate wax for our bite registration, we're going to use 2 thicknesses of pink base plate wax for our protrusive bite. And what we're going to do is we're going to fold it into force and then in half again, such that we will have actually 6 thicknesses of wax when we finish. We're going to put this again in our water bath and soften the wax up. Remember, we've got quite a bit of wax that we have to soften at this time. The reason for folding it in this fashion is we will end up with 6 thicknesses, but in the midline we still will only have 2, such that we can adapt the wax to the arch form of the patient. So we're just going to fold over the edges on each side, soften again, it looks like this, and what we can actually do is we can separate in the middle to accommodate the arch form of the patient. We're going to soften this up a little bit more before we go back to the patient. We're going to insert this in the patient's mouth, and we're going to press it against the maxillary arch, and then have the patient move into the protrusive motion and then incise into this wax all in one motion, so that we get nice crisp indentations. You have to widen it just a little bit more. Okay, bring your jaw forward, a little bit further forward, incise, keep going until your teeth touched. In doing this, it oftentimes is very difficult for the patient to reproduce this bite. So it's important that we maintain this position while the wax cools. And open. Slowly tease it off. And when we look at our registration, we can see we've got nice crisp indentations of the maxillary teeth. We have nice crisp indentations of the mandibular teeth. And we can see that in the anterior area, the wax is very thin, so the anterior teeth just came into contact. And we can lay this aside, and we will use that to set our condylar inclination. Having taken our protrusive bite, we're now going to proceed, and we're going to take 2 lateral check bites, a right and a left lateral check bite. And what we're going to use this for is to set our Bennett angle on the articulator. Again, it's important to practice with the patient before you try doing this in wax. And like previously, we had the patient bite in a protrusive motion. What we're going to ask the patient to do is move in a straight left motion and try and bite in an edge-to-edge position in a left lateral position, and then open. For the second bite, we'll proceed and capture a right lateral motion. In order to conserve time, I'm only going to demonstrate one of these on the patient on film, but we'll actually take 2 separate bites, one for left lateral and one for right lateral. I've prepared a wax bite similar to the protrusive. Again, we're going to be using 6 thicknesses as before. We're going to place it in the patient's mouth, adapt it against the maxillary teeth, have the patient move into a left lateral position, a little further lateral, and bite and stop. In doing this bite, it is critical that the patient does not move into protrusive movement at the same time, so that what we want to do is we want to capture a straight lateral motion as opposed to a lateral protrusive motion. Again, we're going to cool this down. Again, having the patient staying closed in the bite until it cools. Have the patient open and slowly tease it off. And again, we can check and we can see that we've got nice crisp indentations of the maxillary and nice crisp indentations of the mandibular arch. I will go ahead and do the same thing to capture a right lateral motion, and we'll have a protrusive and a right lateral and a left lateral bite. Just to review what we've accomplished today, we've taken our facebow, which has captured the relationship of the maxillary arch to an arbitrary hinge axis using the right and left external auditory meatus, the superior border porion for our 2 reference points, and infraorbital notch for our 3rd position. Having done that, we used a centric relation record to capture the relationship of the maxillary arch and the mandibular arch in the centric relation position. We've taken a straight protrusive bite, we've taken a left lateral bite, and we've taken a right lateral bite. And what we'll be using these for, again, to review this, to mount the mandibular cast in centric relation position, to establish our condylar guidance in a straight protrusive. We will use the left and right lateral bites to set the Bennett angle on our articulator. We're going to use our protrusive bite. We're going to seat it onto the mandibular model. We're going to loosen the condylar elements and the centric latches. We're going to loosen those. Having loosened those, we will seat. We'll move the maxillary arch into a protrusive movement. Before doing that, we need to remove the incisive pin. Having removed the incisive pin, we will seat, move the articulator into a protrusive movement, seat the maxillary cast into our bite registration. And one of the things that we can see from this bite registration that we've reached the outer limits in the protrusive movement this patient gave us. We're reaching the outer limits to how far this articulator can move in a protrusive manner. Having seated this, if we just put our finger on the upper member here and then proceed to adjust the condylar inclination, we can find that if we go too far in one direction, the cast rises out of our bite registration. If we go on the other side direction, raising the anterior, if we loosen this, you find a point that the maxillary cast will just settle nicely into the bite, and we can tighten the condylar mechanism at that point. And on this patient, that is about 15 degrees. We'll go over to the other side. We'll do the exact same thing. Again, holding our finger on the top member, we can rock the articulator forward and back, and you'll find a point where it settles in. We will tighten it, and on this side it also comes out about 15 degrees. It is probably more common that they come out different than in this instance where they came out alike. It is very unusual for a patient to be perfectly symmetrical, that you come out with the same reading on both sides, but in this case we did. Now we will proceed and set our Bennett angle using our lateral check bites. When using our lateral check bites, it's important that we loosen the centric latch on both sides of the articulator, that we loosen the Bennett movement on both sides, and also that we loosen the condylar inclination on both sides. If you remember, just a minute ago we went ahead and set our protrusive path, but on a patient it is very rare that the protrusive path and the orbiting path are identical. So for this purpose we need to loosen this mechanism. We've recorded that the protrusive path is 15. We make note of that. We're going to go now ahead and we're going to set our Bennett angle, and we're going to capture the orbiting path. Having loosened up both sides, we'll go ahead and set the orbiting path for the right condyle, and we'll, again, just as we did before, put pressure in the upper member, and we can see that as we rotate this, the upper model rotates out of the bite, and we find the position where the bite is stable, and that is our orbiting path. Once we've established the orbiting path, we can establish the Bennett angle. And it's important to remember that if we take a left lateral excursion, we're going to use the left lateral excursion to set the right Bennett movement. And what we're looking at is this area right in here where the condylar ball seats against this little ring here. And what we need to do is, as we move this, we can see that the condyle moves away from that little ring, and the correct setting is such that we move the condylar mechanism until the ball contacts that ring, and then we can tighten the Bennett angle, and we've established the Bennett angle for the right side on this patient. Having done that, we will insert the right lateral check bite and set the left Bennett movement. We've now inserted the right lateral check bite, and we're going to set the left condylar orbiting path and the Bennett movement. We've loosened this. Similar as before, we're going to rock the mechanism. So there's minimum rock, and we're going to set the orbiting path. When we look in here again, we can see that the condyle is not seated against the little ring. We will rotate the Bennett angle adjustment until it contacts, and we will tighten. And now we have set both the orbiting path and the Bennett angle on the right and left side. To review what we have Bennett angles on the left side of approximately 15 and 16 on the other side. Our orbiting paths on the left side is 40, and on the right side is about 30. And now we need to make a decision: are we going to use the orbiting path, or are we going to use our protrusive path? Because there are two separate paths, and we cannot use both of them unless we want to change the articulator every time we move from a lateral movement to a protrusive movement. If you remember that the steeper that the condylar path, the higher the cuss tip. And so if we're going to err, it's better to err on the more conservative side with a lower cuss tip. So at this point, we're going to make a decision that we're going to use the protrusive path as opposed to our orbiting path. So we're going to go back and we're going to adjust our anterior condylar guidance to 15, which is what we determined when we used our protrusive bite. So in review, what we've done is we've used our protrusive bite to determine our condylar inclination in a straightforward motion, and we've used our right and left lateral check bites to establish the Bennett angle. At this point, we want to review and see what kind of slide we have on this patient. The slide, if we duplicate the slide on our models, we find that when our first contract in centric relation, the midlines are on, and we Move into CO, our midlines are still on. We've got about a millimeter slide in pretty much a straightforward motion, which is similar to what we had in the patient.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.